Good evening, everyone. Thank you for joining us tonight at the Cleveland Clinic for our next webinar. My name is Dr. Raevti Bole, and I'll be focusing on men's health today along with our panel of experts. This is a live event. None of it is pre-recorded, so it's all about you and what you want to hear from our experts tonight. We'll have a brief presentation followed by a Q&A, and there is a chat feature on your screen. It's called Q&A at the bottom right, and you can use that to ask us questions, which we'll answer during the event. Now, I think you can see that this event is being recorded, but nothing about your identity is being shared, so please don't share any confidential personal information when you ask your questions. Next slide. Can we advance the slide, please? Thank you. I'd like to introduce our urologist experts tonight. They wear many hats, but I want to review their clinical specialties for you so that you know what types of conditions they can each discuss tonight. Dr. Neil Parekh specializes in erectile dysfunction treatment, low testosterone treatment, male infertility, and Peyronie's disease. Dr. Sarah Vij specializes in male infertility, vasectomies, sexual dysfunction treatments, and enlarged prostate. Next slide, please. And Dr. Samuel Haywood specializes in urologic oncology, so that's cancers in urology organs, and prostate cancer screening. Next slide, please. So we'll start with Dr. Parekh. Why should men over 40 see a urologist?
Thanks, Dr. Bole. Thanks for the introduction. I'm looking forward to speaking or answering many of the questions many of the attendees may have tonight. We've got a great panel, and we're all comprised of urologists. So for the audience, many of you may already be experiencing symptoms, but many patients start experiencing symptoms related to urinary issues or erectile dysfunction starting around age 40. So around age 40, it's a great idea to establish or see a urologist. There are a lot of simple, sometimes small, easy lifestyle changes that can be made to address a lot of these issues. Of course, some of these issues are a normal part of aging, but can be bothersome. So we're all here tonight to hopefully be able to shed some light on some treatment options, both easy ones that can be done with simple lifestyle changes or medication changes, or other medical or surgical options as well. Next slide.
Next, we'll hear from Dr. Vij, and she'll speak to us about when you should see your doctor.
All right. Hello, everybody. Thank you very much for attending. So I'm just going to talk about some common complaints that we see from our patients, so things that might prompt you to come in to see a urologist. And these are all things that we can help you with, or certainly point you in the right direction. So the first one, if you see blood in your urine, you definitely need to be evaluated. There's some basic testing that is required in that setting. Additionally, blood in your semen, which can be very concerning for men, we do recommend that you come in. Urologists take care of all sorts of urination problems. So whether it's frequency, you're going way more than you feel you should. When you have to go, you got to get there right away, you're going to leak. Maybe your stream is weak and you're feeling like you're not emptying your bladder all the way. You're waking up at night several times to pee. Really anything related to urination, we can usually offer some assistance. We treat patients with all different kinds of sexual dysfunction. Erectile dysfunction, or difficulty obtaining or maintaining an erection, is probably the most common thing that we see. Alongside that, painful ejaculation certainly is not normal. We see patients who have low sex drive, and sometimes can help with testosterone management for those patients. And patients with low testosterone sometimes will report that they have difficulty losing weight, difficulty gaining muscle. Those things can all be related, and we can help. Anything related to your scrotum, or the area where your testicles live. So if you notice new swelling, new pain, if you notice certainly anything hard or firm that is not normal, we'll have you come in for a physical exam and often some imaging to help us figure out what's going on. Back pain, pain in your hips, your legs, that can lead to urologic symptoms. So maybe we won't be the first stop there, but that can, back pathology can lead to difficulty emptying your bladder and things like that. And then penile curvature refers to curved penis when erect. There's a lot of commercials on TV about treatments for this, but certainly if you have penile curvature that's making intercourse more difficult, we do have treatments to offer. We also do see men who are having difficulty trying to conceive. If it's been over a year and you haven't caused a pregnancy and you've been timing intercourse, certainly important to get evaluated. And then we offer sterilization procedures to people who are done having children, and we can help sort of on the male side there. So that's just kind of a sampling of common symptoms that might bring you into a urologist.
Thank you, Dr. Ridge. That's definitely a wide range of symptoms here. Finally, we'll hear from Dr. Haywood about PSA screenings.
All right, well, thank you, Dr. Bole, and appreciate everyone logging in today, and look forward to helping out with any questions y'all have. One of the things that I get the most questions about is prostate cancer screening, because it can be confusing, and there have been some conflicting opinions on it in the past couple decades. So PSA is a screening test for prostate cancer, and it stands for prostate-specific antigen, and it's a blood test. And unfortunately, it's not a perfect blood test, but we in our hands we use it to gauge the risk of prostate cancer. That can then lead us to consider doing kind of more, more specific testing. The guidelines on screening have changed over the past couple, about 5-10 years. The way that we talk about screening now is that for most men, they're starting screening between the ages of 50 and 55. So for men at average risk for prostate cancer, we recommend to screen at age 55. However, in certain populations of men that may be at higher risk, we advocate starting a little bit earlier. So in particular, African-American men, if they have certain genetic mutations or a family history, we recommend starting even age 50 or 45. And so this can all be kind of very difficult. And so a lot of times the biggest thing that we recommend to do is make sure you bring it up to your primary care doctor, initiate the process for screening, and then if there's any abnormalities or any concerns, then urologists are happy to see you and help evaluate it.
Thank you for that, Dr. Haywood. So with that, we'll move to the Q&A, which we really want to be the majority of our discussion tonight. And we already have some questions submitted, which is fantastic. So we'll start out with those. And please continue to submit your questions via the Q&A box at your bottom right of your screen, and we'll get to as many as we can during our session. So for our experts, our first question here is about prostate enlargement. That's also referred to as BPH. Now, we know that many people are more interested in living a healthy lifestyle, so eating healthy, exercising, getting enough sleep. The question is, when you have an enlarged prostate, are there healthy lifestyle choices that you can make to help keep your prostate healthy? For example, are there certain foods that you should avoid eating? Or even, are there some certain environmental factors that you should avoid using, like plastics, for example?
I can take that one. So I think the answers to these questions can be difficult because it requires a really, really large study and a large population of men. And so most of the data that we have on certain sort of natural supplements or herbs or things like that is in medicine in general, but certainly in BPH is not, the data is not super strong. So there is, you may read about saw palmetto, which is a supplement that men can take that has been shown in some studies to improve the symptoms of BPH. And generally the risk to these type of supplements is pretty minimal. So if a patient, initiates it and feels like it helps them, by all means, very safe to continue. In terms of diet and exercise, there's really not been anything specific that's been shown. What I tell my patients really for all urologic problems is things that are generally that we know are good for us. So eating, lots of fruits and vegetables and lean protein, getting exercise, stress reduction, all of those things are going to be good for your urologic health as well. But unfortunately, we don't have high level data saying, if you eat lots of tomatoes, for instance, it's going to reduce your BPH symptoms. We just don't have that level of clarity. And I'm not aware of any connection between plastic packaging and BPH symptoms. So I think to me, the message is, if you're having symptoms that are worrisome, come see us. We can help guide you. I think saw palmetto is probably the one where we have the best data in terms of a sort of a natural supplement for symptom improvement.
Yeah, I agree with Dr. Vidge's. I echo her sentiments regarding the lack of quality studies when it comes to herbals and antioxidants and diet in general. But there are some things to avoid. We know that there are certain things that we ingest that can worsen a lot of our urinary symptoms. So you want to avoid smoking, avoid alcohol, as alcohol is a diuretic and can make you urinate more often, and that's similar with coffee and teas. Even if the coffee you're drinking is decaffeinated, the acidity of a lot of these fluids can irritate the lining of the bladder and make patients go more often. So it is important to be aware of the things the fluids that you consume, and also the food that you might be consuming. So there are some data to suggest maybe diet in high fat or red meat may also worsen prostate health. Again, more data and studies need to be done, but those are just some simple things that you can avoid to try and reduce some of your urinary symptoms.
Thank you. That makes a lot of sense. We had some other questions right as soon as we started the topic of supplements on specific supplements with a few brand names thrown out. I think from what you're saying, from what everyone has said so far, it's really hard to know about specific supplements, especially if they are labeled as proprietary or we don't know all the ingredients in them. And as our experts just said, there are maybe some that have some limited data available, but for the vast majority of these, we're not going to have good scientific studies to give us information on most of these, especially some of these blends that are called proprietary or where the ingredient list is really not clear. Would that be accurate, experts?
I think so. And the other thing I just warn my patients is these supplements, like I see on the chat, Prostadine, they don't go through the FDA approval process that our normal medications go through. And so they can really put whatever they want in these supplements and they don't even have to list it on the label. So it's a big money maker. And again, there probably is some benefit for some things. We just don't really have the answers. And I worry a little bit that there's not a lot of control of this industry. So you don't know exactly what you're putting in your body.
That's great advice. On the subject of urinary symptoms, there's some interest in the chat about the possible options, some of the surgical options, especially if a medication, for example, someone mentioned tamsulosin, if a medication's not working. Can we chat a little bit about what types of surgical or interventional options are available via the urology specialist?
Sure. So when we typically start with lifestyle adjustments, as Dr. Parr kind of alluded to, for urination symptoms. Then we try medications. When those fail and patients are still symptomatic, we often will do some more diagnostic testing, like to study how the bladder empties, to look at the prostate under direct vision with the scope. And if it does look like the prostate's enlarged, and then we feel that that's leading to the patient's symptoms, there are several different treatments for BPH. And we do offer, I believe, all of them at the Cleveland Clinic now. Many are newer. So again, the long-term data on them is still evolving. There are office-based procedures, namely UroLift and Resume, that are done in awake patients in the office. And then we have several options to treat the prostate in the operating room that generally involve tissue destruction of the prostate gland through several different mechanisms. Lasers, sometimes just actually removing the tissue itself. And the side effect profiles for all of these vary a little bit. There's sort of a lot of complexity and nuance to it. And so I would definitely encourage you all, if you're at that point, to come in, speak to one of our BPH experts and learn which procedure might fit you the best.
I agree with Dr. Bish. One size doesn't fit all. Everyone's prostate often has unique anatomy, different sizes, and a lot of the different procedures that are available are indicated for different types of prostates. So we all work together at the Cleveland Clinic, and if there's a certain procedure that you may be a candidate for and you are seeing someone that does not perform the procedure, we'll be happy to refer you to someone that does.
That's really good to hear about the team approach here at Cleveland Clinic. There has been some interest in the chat, and certainly every time we see patients who have urinary symptoms, about all the different kinds of options, because it's definitely confusing with the new treatments and all the new names that come up. Everyone wants to know what the best one is. I think the takeaway from what our experts have been saying here is that there are so many different options. It's going to be a very individual discussion between you and your surgeon as to which one's right for you. And everyone works here very collaboratively. So you will be referred to someone if you're interested in a certain procedure that the person you're consulting with maybe doesn't do. So on that note, can we talk a little bit about what types of symptoms may be most affected by a procedure? For example, suppose a patient has more of frequency and urgency rather than a weak stream or trouble emptying their bladder. Are symptoms sometimes a consideration in terms of what type of symptoms they are?
Yeah, I think the symptoms are a really important part of the equation. It's really important to differentiate in many patients. Are the symptoms more obstructive in nature? Is it more of an issue with the flow, generating a stream? Or is it more irritative in nature? Is it the frequency, the urgency? Because that may affect the type of medications that we would prescribe first line, and that ultimately, if they don't work, could affect what type of procedure you'd be a better candidate for. Just because you're having a lot of frequency urgency doesn't necessarily mean it's due to an enlarged prostate. As Dr. Bish discussed, we would most likely perform some more diagnostic testing, such as cystoscopy or an ultrasound or another procedure called urodynamics. I kind of explain to patients it's like an EKG of the bladder. And it gives us more information on the bladder capacity and its function and how often it's contracting. So if we find that a patient is having more of the irritative symptoms, so the frequency, the urgency, a prostate procedure to open up the channel may not necessarily be the best fit. There are other procedures that we offer, such as Botox or InterStim or tibial nerve stimulation.
That's really helpful. Thank you for elaborating on that. Let's switch gears a little bit now and talk a little bit more about PSA screening and testing, because we've had some more questions come up in the chat about that as well. One of our listeners tonight is wondering about the need for PSA testing after the age of 70, so outside that guideline range that we were talking about. Would anyone like to speak to that, as opposed to how often is testing warranted? Is it still warranted after a certain age?
Sure, I'd be happy to talk about that. The decision on when to stop screening is also pretty pretty nuanced. The guidelines that we have, in general, say that you can stop screening around age 70. That said, there's a lot that goes into that decision. So for men that may be in particularly good health, where they may have a significant life expectancy left at age 70, or if they have any other reason like a prior elevated PSA, we may still track them as they age past 70. So that's often something that I'm using shared decision making with the patient to try and decide sort of when to when to stop the screening there. The other thing I bring up is that we often will de-escalate or screen less frequently for some of those patients. So even if a patient feels uncomfortable to stop screening, maybe we'll go to every 2 years, every 3 years, really to limit the risk of overdiagnosis and overtreatment for patients.
Thank you. And just to piggyback off of that question, can we speak a little bit towards how a prostate MRI might help guide the decision to do any more treatment or not?
Yeah, so the prostate MRI has really changed how we practice in the past couple of years. It used to be that we would get an elevated PSA, we make a decision whether or not we would do a biopsy based on that. More recently, the guidelines have included doing an MRI before a biopsy, and so for most men with an elevated PSA, I will get an MRI beforehand for two reasons. One is that it helps me decide if a biopsy is warranted. So the MRI really helps us to see the exact size of the prostate so that we can determine if the elevated PSA might be because of an enlarged prostate. It also helps if there is a spot that they see, we can do some special targeting of that particular spot so that we can have the most accurate biopsy. And not all men's insurance will allow them to have an MRI beforehand. If that's the case, then we have some special ways that we can kind of work and try to make sure that all men have that benefit.
That's really good to know. Now, are there other tests apart from an MRI that might help you decide whether someone's elevated PSA is worrisome or not? So, for example, some of the other adjunct tests, still PSA based, but giving us a little bit more information in terms of risk level.
Yeah, that's a great question. So there's I think 3 commercial tests that that I'm aware of that we use frequently. The one that I probably use most frequently is ISO-PSA, which we developed here at the Cleveland Clinic. All the tests, regardless of which one we use, are generally employed in men with a PSA between 4 and 10. And that's sort of what we call the sort of questionable zone. It's not a slam dunk to get a biopsy, but it's also nothing we want to just brush off. And so I use those tests for men that are undecided or we're sort of debating whether or not to get a biopsy to try to push us one way or the other. The decision about which of the tests to use can be a little bit more tricky, and so that's often something we'll decide with the patient depending on insurance coverage or what tests are available in their area. But there are some great tests that have come about in the past 5 or 10 years that really help us decide who really should or shouldn't get a biopsy based on their results.
That's a really good explanation of those adjunct tests. So just based on some more sort of specific questions in the chat here about specific PSA levels, it's sounding like Dr. Haywood's telling us that if your PSA level is concerning, there are other testing options that can be done to try and help you and your urologist decide if you need to do a biopsy. Some of those are going to be blood tests. Some of those are going to be imaging tests like an MRI of the prostate. But essentially, if your PSA is elevated, there are ways for us to determine whether or what the next steps should be. Now, we do have a question from one of our listeners here about being diagnosed with prostate cancer. They're particularly interested in the type that's called Gleason 3+3. And some experts saying that that isn't even a cancer. Can anyone speak to that a little bit about the terminology and our thoughts as they've evolved over the years and the decades about Gleason 3+3 and what that really means?
Sure, I'd be happy to take this one. So Gleason 3+3 prostate cancer, you might also see it written down as grade group 1, depending on how the pathologist report reads. In most patients, that's classified as a low-risk prostate cancer. Now, to the question that was asked, there's actually some debates at our conferences we go to about if we even should call it cancer. Because, as a general rule, we suspect this not to be a life-threatening cancer. The low-risk cancer has a very, very low risk of spreading, moving somewhere else, causing a man problems. There are some interesting or uninteresting, depending on how you look at it, reasons from a pathologic standpoint why we still call it cancer. But the fact of the matter remains that this is a cancer that's very unlikely to cause a man significant issues in his life. And so because of that, over the past 10 to 15 years, we really tried to push hard this idea of active surveillance, whereby we don't immediately move towards surgery or radiation, but rather watch the cancer very closely. Now, a lot of men, the first time I bring that up, they look at me like I have 3 heads, because they're like, "What do you mean? I have a cancer, you're going to watch it." But as I said, it's a very, very low risk of causing issues, and all the treatments that we have for cancer, unfortunately, can cause some side effects. And so we think that by watching it very carefully, we're able to decide when exactly we should move towards treatment, but in the meantime, allowing men to preserve their current sexual and urinary function that are so often affected by cancer treatment.
That's really helpful, Dr. Haywood. So I hope that answered our listener's question about 3+3. Certainly, I'm seeing some other questions about different types of pathologies like 3+4, et cetera, et cetera. Essentially, the more, different pathologies are going to confer essentially different types of information to your urologist, and you'll be discussing that information usually with a urologic oncologist like Dr. Haywood, and that's going to be a little bit more of a personalized decision for treatment. Dr. Haywood, do you have any thoughts you'd like to share on just general treatments for when treatment is indicated for prostate cancer?
Yeah, so with regards to that, so for starting off with the low risk cancer that you mentioned, for the most part, we're pushing those, we're talking to those guys about active surveillance. That said, it's always an option to do a surgery or radiation. We really do, think that for most men, the surveillance is great for that low risk cancer. As we start to get into the more intermediate and high risk cancers, we start to talk about the options of surgery and radiation, more readily. As far as which one is better than the other, unfortunately, they are both great options. The studies we've done show that both surgery and radiation, in general, treat the cancer very, very much the same. Where they differ is in the side effect profiles, and getting into the differences between the two of them is probably more than the scope of this webinar. However, there are some very different side effects, and so often when talking with men, as we describe the different side effects, they do find themselves leaning more towards one or the other option. And so it's in general, a very long discussion that we have. And so I think, if the different cancer options is of interest to you, that's certainly something that we'd help with an appointment. I also often will encourage patients to get an opinion with a radiation oncologist or a second opinion with another surgeon as well. Because it's a big decision, and making sure that you've thought about all your options is really important.
Yes, very important to get all the information you can by making an appointment with a urologic oncologist and with a radiation oncologist, as Dr. Haywood said. And if you see us in clinic, we'd be happy to refer you to our colleagues in radiation oncology if this is a situation that applies to you. So just going off of what Dr. Haywood just said about the symptoms often being, or the side effects rather, often being what helps patients decide which way to go, given that a lot of these treatment options are really all very effective at treating the cancer. Let's switch back now to some of our questions about enlarged prostate surgeries. What should we be asking our surgeon in terms of some of the potential side effects from the different prostate cancer surgery options. If we could just speak a little generally about potential side effects on urination or sexual symptoms or whatever else, what should we be asking when we come to this consultation?
Sure. So to start, it's important for us to have a good sense of the patient's of overall health. So patients on blood thinners or patients with significant cardiac disease, we may offer a different set of recommendations than somebody who's, completely medically healthy. So we need to have a sense of the patient's overall health, and then their prostate anatomy is important. So we generally need an assessment of their prostate size. Very, very large prostates, which is like over 100 grams, tend to do best with what's called a simple prostatectomy, which we can actually do robotically. There also are some surgeons that do laser vaporization for prostates that large, but having a sense of the size is important. And then, and we can get that usually if you've already had a CT scan. Sometimes we'll do a transrectal ultrasound in the office, which is a pretty quick procedure without significant pain, just to assess the size of the gland. And then we typically will do that scope procedure I mentioned earlier in the talk to get a sense of the prostate anatomy kind of from the inside. Some patients have what's called a median lobe, which is a little lobe of the prostate that's right kind of in the midline of the prostatic urethra. Some patients also have prostate gland that's sort of bulging into the bladder, and all these things anatomically sort of are important for us surgically. So, each individual patient's going to have sort of a menu, and then we might ask the patient, how they feel about specific sexual side effects. So primarily changes to ejaculation. So many men after prostate BPH treatment will have either no ejaculate or very little. Just keep in mind, ejaculation and orgasm are different. So orgasm should not change. It's just the fluid that comes out at the time. There are some options, particularly the office-based procedures like UroLift, that can have a lower chance of having ejaculatory symptoms afterwards. So kind of getting an understanding of the patient's lifestyle and what's important to them, and then, assessing their risk undergoing the various procedures. So it's a complex discussion, but every patient really is going to have kind of a menu to choose from.
That's perfect. So just to summarize for our listeners, essentially you're going to get a menu of options based on the workup that your urologist does, and this is going to depend on your anatomy and other tests that you've had done, as Dr. Vij said. And then you're going to be asked what things are most important to you, and then you're going to get the chance to choose along with your urologist. So again, that's where that consultation visit really comes in handy, so that your personal questions are something that can be discussed in terms of each of those specific treatment options. And I did see some mention of things like UroLift and Resume and TERP and PVP, and all of those things are going to depend on your specific anatomy and personal history, as Dr. Vij was saying. So the next few questions are for a different topic. Some of our listeners are interested in erectile dysfunction treatment. So one of our listeners today asks, is it safe to be on erectile dysfunction medication if you've had cardiac bypass surgery or if you have cardiac issues? What are some considerations that a patient with cardiac issues might have when they're seeking treatment for ED?
Yeah, I can take that one, Dr. Bole. So, of course, ED and cardiac issues often go hand in hand. As we discussed earlier, one of the other reasons patients may be wanting to come in to see a urologist in their 40s is the development of erectile dysfunction. Oftentimes, like most guys, they're pretty reluctant to see a primary doctor or a urologist in the first place. And oftentimes, the first symptom that brings them into our office is their ED. But unfortunately, ED can also be one of the first signs or symptoms of underlying heart disease. So as urologists, it's something we're all very familiar with. So specifically, when I guess answering the question about using treatment options like phosphodiesterase inhibitors that can include medications like sildenafil or tadalafil. Also, the brand names are Viagra or Cialis. The main contraindication to those medications are if patients are taking nitrates. So nitrates and taking one of those medications can cause a significant drop in your blood pressure. So taking those two together within a 24, 40-hour period is ill-advised. So that's something we check before prescribing those medications. Now, I think this listener specifically also asked about after having a CABG procedure. So after a CABG, there's obviously a recovery period. Usually takes about 6 to 8 weeks for the sternum to heal. So after that's healed, then there's usually really no contraindication to sexual activity. But this is also something that is discussed with their cardiologist or heart surgeon. So again, at the Cleveland Clinic, it's very collegial. We are able to communicate with not only other urologists, but other specialties within the Cleveland Clinic. So when patients come into the office with concerns about their heart health in relationship to their sexual function or ED medications, it's something that we routinely communicate with their heart doctor before really making any significant changes or recommendations.
That's really helpful to know. Thank you, Dr. Parekh. Another question that someone's just written in about is that one of their testicles seems to be swollen. Is that something they should worry about? So swollen, I'm not sure if they also have pain, but would one of our experts like to talk about what testicular swelling might signify and why that might be a reason to come in?
Yeah,
Sure.
happy to take.
Go ahead.
Yeah, happy to talk about it. You know, there's several things that can cause some swelling, whether it be just some fluid around the testicle, some inflammation or infection, but also can be, you know, like a tumor or something. And so, you know, I don't want to start everyone worrying about it. So it's not something to start losing sleep over, but I would recommend getting checked out by your primary care doctor or coming to a urologist. In general, based on your exam, a lot of times we'll do an ultrasound of the scrotum, which is a pretty quick test that allows us to see if there's any fluid around the testicle, any masses, the blood flow to the testicle. It's pretty quick, pretty painless, and so it doesn't use any radiation. So it's often our first test to evaluate any sort of swelling. But a lot of it can be determined just from a physical exam. So the first thing I recommend is to have patients that notice this go into their physician.
Perfect. Dr. Vidge, did you have something to add about that?
No, I think that's a good summary. I think ultrasound of the scrotum is a really good test to help understand what's going on anatomically. And so, you know, there's no pain with that. It's a pretty quick test. So certainly any new and different findings that you notice, it's pretty simple to get it checked out. Unfortunately, most of the time it's going to be benign or non-cancerous, but it's just always better to be, you know, safe than sorry.
That's very reassuring. Sounds like a simple test and a physical exam can give us a lot of information for men who are experiencing swelling in the testicles. Let's talk a little bit now about some patients have questions about urine color, urine odor. When should they be worried that they have a UTI? Should they be worried when it smells kind of funny? Should they be worried when the color is darker than normal? Should they get urine testing for something like that?
Yeah, so that's a pretty common question I receive in the office as well, is, you know, that might, if their patient's urine smells funny or looks funny. So really, you know, I explain to patients that your urine is eliminating a lot of the toxins from your body, and it is usually a result of your diet. So things that you may have eaten, fluids that you drank. So first thing I ask them is, especially if it's foul smelling, kind of intermittently coming and going, it's oftentimes what they may have had in their diet preceding that. And more often than not, it's typically something that they ate or drank. Of course, if patients are having not only foul-smelling urine, but other symptoms, burning or pain with urination, blood in the urine, or if they're having any pain elsewhere, fevers, chills, those could potentially be signs of infection. And of course, we want to assess for that, and that can be done with a simple urine analysis or urine test in the office. And in that case, where we can send a urine culture and assess to see if there are, in fact, bacteria growing, and then patients can be treated appropriately. But more often than not, the foul-smelling urine is dietary related. And I tell patients to drink more water. That usually solves the issue. Dehydration can result in more concentrated urine. And because the urine is eliminating a lot of the toxins, the more concentrated it is, the more likely it is to have a foul smell. So drink more water, and that tends to resolve the issue.
Perfect. Thank you for that explanation, Dr. Parekh. So hopefully our listeners have some reassurance about seeing some of those findings in their urine. I will say that if you're seeing blood in your urine, that would not be normal. That you should definitely see a doctor about. But for foul smell or just a darker yellow color, I think we're reassured by that explanation of why that can happen. It's understandable though that if there's a urine coming out and it's not looking quite right, that can be alarming. Something else that people find alarming, and one of our listeners or a couple of our listeners are asking about, is blood in the ejaculate. It can be pretty alarming to see that the ejaculate color is not what is expected. So maybe a rusty brown color or even a bright red color, whether it's just happened one time or it happens multiple times. Would someone like to speak about what that could represent, whether that's worrisome or not? Is it usually benign, and what should be done about it?
Sure. So blood in the semen, the medical term is hematospermia, is a concern that we see in the office all the time. It is very common. Fortunately, for the great majority of men, it's benign and self-limiting. Meaning it's just going to go away with time. Usually it is from prostatic bleeding. So the way I explain it to my patients is it's like a nosebleed, but of the prostate. So just a little tiny blood vessel kind of pops open, and you sort of notice it in the ejaculate. And for most men, once they ejaculate a few more times, that blood is sort of cleared and the ejaculate goes back to normal color. If the patient is of the age where they should be getting prostate cancer screening, I will typically check a PSA, just again to be sure that there's not a cancer leading to this finding. Unfortunately, that is rare to have prostate cancer present that way. Some people will treat with antibiotics, the thought being that there may be an infection in the prostate gland leading to some irritation and bleeding. That's sort of provider specific and I think dependent on the individual patient situation. So we do sort of some basic testing and evaluation and get a history. But again, for the great majority of guys, it's just going to go away. A very small percentage have very persistent, very troublesome, substantial bleeding. And there are some things that we can pursue, medications to shrink the prostate, surgical procedures. But again, to get to that point is usually the more rare scenario.
That's good to know. So for anyone worrying about that symptom, certainly something that you should mention to your doctor, but in many cases, it is something that will go away on its own. So once you receive that reassurance in your specific situation with your medical conditions, once it's all been looked at, the thought is that it should go away and stay away for most people. Now, we do have some listeners tonight who want to talk a little bit more about the sexual experience as it relates to libido. Can we talk a little bit about patients who are experiencing low libido, so lower desire to have intercourse, and how this potentially could relate to other medical conditions like, for example, thyroid issues, low thyroid?
Yes, low libido is often a very bothersome symptom for many patients. It's an important part of their lifestyle and can not only affect them, but also their partners. And there could be a host of different causes of low libido. So when you come in to see a urologist, we're typically kind of assessing your history, any changes. These could be lifestyle changes. These could be new medications, could be stressors in your life. There are a host of conditions that can affect your libido or sex drive. Once we've ruled out, any sort of medication side effects, one of the most common ones that we see is antidepressants like SSRIs, and we've ruled out other medical conditions. We can then move on to maybe checking blood work and checking something called a testosterone level. But going back to the thyroid function, low thyroid function can also present with low libido, fatigue, or tiredness, and a lot of the symptoms of low testosterone are similar to some of the symptoms of hypothyroidism or low thyroid function, and a lot of other medical conditions. So sometimes it's difficult to tease out, is this from low testosterone or is this another medical condition? So that's why we often have to order blood work at this point to really kind of assess the overall picture and make sure we're not missing anything else that could be contributing to the low libido, low testosterone. So once we've obtained the blood work and we've made sure that there's no other medical condition causing these symptoms, and you in fact have a low testosterone, then there are treatment options that we can provide to help address low testosterone.
And in what ways can low testosterone also affect other things like, for example, erectile function?
So testosterone, normal levels of testosterone is important for sexual function. Oftentimes, just normalizing the testosterone alone may not cure the erectile dysfunction, but it may make a patient who maybe is using Viagra and getting mediocre results normalize their testosterone. They may do better. I do find in my younger patients in their 20s and 30s that sometimes treating the testosterone alone, if they do have low testosterone, can significantly improve their sexual function. But I think as men age, aging alone is a risk factor for erectile dysfunction, and oftentimes there's other conditions like high blood pressure, diabetes, etc., that just correcting their T alone is often not quite enough. But if it's indicated and the patient is symptomatic, it's certainly something that we can discuss and talk about the risks and benefits of.
On the subject of erectile function, someone's asking, how effective is the ultrasound treatment for erectile dysfunction or ED? And I think what they're referring to may be shockwave treatment. Would anyone like to speak about the data that we have currently about that, or what we know about how effective it might be?
Yeah, sure. So Shockwave has been, I guess, hit the market maybe in regards to being used to treat erectile dysfunction about 5 years ago. There's been a significant amount of direct-to-consumer marketing. Most of my patients have seen ads on TV, heard radio commercials or newspaper ads, basically promising that this sort of treatment is going to be a cure-all for their erectile dysfunction. And unfortunately, many of us have also seen patients who have spent thousands of dollars at many of these places without much success. So at the Cleveland Clinic, we do offer low-intensity shockwave treatment, but we are also setting the stage or selecting patients appropriately to who we think would be good candidates for shockwave therapy. Because in the studies that we've done, not only at the Cleveland Clinic, but studies that have been done at other institutions, really only find shockwave therapy to be effective in men with mild or moderate erectile dysfunction. So we define patients with mild or moderate erectile dysfunction as those that where the pills like Viagra and Cialis work well, and maybe patients would like to try and get off those medications, and those patients may benefit from low intensity shockwave. to try and get a more spontaneous erection. Also, patients who may have been using medications like Viagra and Cialis, and maybe those medications really have not been working as well in the past 6 to 12 months. Those patients may also get a benefit from low-intensity Shockwave. It can get them back to where the medications are working again. But we typically do not recommend this type of treatment in patients where they have very limited or no success with medications, or if they've failed other treatments like intracavernosal injections for erectile dysfunction, or if they've had surgery for prostate cancer or other sort of pelvic surgery or radiation, the success rate is much lower. The other issue is, although the treatment device that we use is FDA approved, using it to treat erectile dysfunction is not FDA approved yet, and therefore is typically not covered by insurance. So it is an out-of-pocket cost. We at the Cleveland Clinic, we charge about $300 a session, so a total of $1,800 for the treatment. It can be much more at other places, but we're also very selective in who we treat.
That's really, I think, important information, Dr. Park. Thank you, because there is a lot of advertising about Shockwave and different treatment options out there, and it is so important to make sure that you have this discussion with a urologist and make sure that you're getting the right information about whether this is likely to work for you or not, because you, as Dr. Park said, if it's not covered, you certainly don't want to be pursuing a treatment option that's unlikely to work. So that's really important. Can we speak a little bit more, just as we're finishing up here, are there any considerations if you're having problems with erectile issues after treatment for prostate cancer? For example, if you're 6 months out or a year out, when could you still expect improvement, and what are your next steps if you're not really seeing improvement after the treatment that you had for your cancer?
So I often, for men that I've treated for prostate cancer, I often encourage them to wait 6 to 12 months for any recovery before we go down that road for, either erectile issues or urinary leakage. Beyond, once we, with respect to erectile function, once we get to that point, we start with the medications. If medications are not working, the other options that we routinely will talk about are like vacuum erection devices, which I offer to patients. I will say most are not excited about that. The other options being like intracavernosal injections, where they inject medicine into the penis itself to cause an erection. And then finally, if nothing else works, then they can have a procedure where inflatable penile prosthesis is implanted to help with that. While most patients, as soon as I bring that up, are a little shocked about another surgery, I will say the patients that we see that have those procedures are very, very happy. The studies we've done quote a very high rate of patient and partner satisfaction with the inflatable penile prosthesis.
Fantastic. Thank you, Dr. Haywood. And we are coming up to the end of the hour, so I think that's going to have to be our last topic tonight. Thank you so much, experts, for sharing your advice tonight on everything men's health. We can advance to the next slide here. I think you can all see that our urologists work very closely and collaboratively with each other. And so certainly for any of these conditions that we've discussed tonight, or any other conditions that a urologist sees, you certainly will be directed appropriately to one of our team members based on what your concerns are. So as we wrap up here, it's been a really great discussion. We would love to continue talking to each of you. If you're interested, you can call the number that'll be at the bottom of some of the slides to schedule a consult, and we'd be happy to see you to chat more. This talk was recorded, so if you want to watch it later, or one of your friends wanted to watch it and missed it, you will be emailed a copy of the talk that you can share. And then finally, we do have some more great webinars coming up in our series, so please go ahead and sign up and you'll be the first to know about them. Thank you all so much for tuning in, and we'll see you next time. Bye for now.